Yes, I will carry on. The next session is a lunch symposium, which is sponsored by the Pfizer Foundation. There will be 3 sessions on this subject. First, we will start with the opening speech or opening remark from our chair of the CMAO 2021, Professor Ronachai, and will follow by the second session will be the reinforcement strategy for successful smoking cessation in Taiwan. That will be presented by Pin Kyo Fu. And the third session will be the same, the reinforcement strategy for successful smoking cessation in Thailand by Associate Professor Dr. Suthat Rungrueng. Now, may I invite our chair to give us opening remarks, please.
Thank you. Thank you very much, Professor Wancha Supatchatulat, for your best introduction of me for this luncheon symposium. So I would like to start my session. Sawadee krab. Welcome you all to the luncheon symposium of the 30th APACT 2021. I'm very honored to be the moderator on the topic of the reinforcement strategy for successful smoking cessation. I would like to give my sincere thanks for Pfizer to support this value program for the APACT. First of all, I would like to give my disclaimer that the content that will be presented, the opinions and experiences of the respective participants do not necessarily represent the views or recommendation of Pfizer. I myself, as the president of the APACT 30th, I would like to give my welcome message. And I want to keep my theme of this meeting is for Asia Pacific e-cigarette-free society, because we would like to call up you all to moving together for a tobacco-free society. Smoking is a very costly burden of patients and healthcare system, because smoking is the leading preventable cause of death. It's causing nearly 8 million deaths annually. And as we know, nearly 80% of the world smokers live in low and middle income countries. As you see from the map, the Asia Pacific region. And average 25% by the year 2025 will have the prevalence of the smoker about 25%. So it's quite high. And the leading preventable cause of death in the world, as we know from the study of the WHO, give us this picture that tobacco use is a risk factor for 6 of the 8 leading causes of the death in the world. So the WHO tried to have a very powerful program to call out for the nationwide, try to implement the tool, try to have the tobacco control. As we know about the FCTC is the World Framework Convention on Tobacco Control, and also we have Empower. Empower we quite very used to it. The Empower is composed of, monitor tobacco use and prevention processes. The second, protect people from tobacco use. Thirdly, offer help to quit tobacco use. And the fourth, warn about the dangers of tobacco. And the fifth is enforce bans on tobacco advertising, promotion, and sponsorship. And lastly, raise tax on tobacco. All of these 6 measurements will give a big support for the tobacco control in each country. Today, I would like to straight the point of how to offer help to quit tobacco use. So it comes to our topic today, the reinforcement strategy for successful smoking cessation. So today I have two very important speakers who will share their experience and their knowledge to us how to make a very successful smoking cessation. So the first speaker for our topic will be Dr. Phúc. Dr. Phúc currently works in Day2 Veterans General Hospital. He is the Director of Respiratory Intensive Care Unit and the Director of Smoking Cessation Treatment and Management. So he has so many background that will give us a very good experiences. And he has a lot of research, especially in chronic respiratory tract disease such as COPD, interstitial lung disease, and severe asthma. So he got so many publications in the last 3 years. So please welcome Dr. Phúc. Please, Dr. Phúc.
Thank you for inviting me to join this discussion. Today, my topic will be reinforcement strategy for successful smoking cessation in Taiwan. I'm Dr. Fu from Taiwan Veteran General Hospital. This hospital is a medical center located in central Taiwan. The order will be, first I will talk about the best way for chronic ear, for example, diabetes, hypertension. The best way for chronic ear disease is risk reduction. And smoking cessation will be benefit for all patients, including lung cancer, another cancer, or chronic ear disease. And the last I will talk about smoking cessation is a journey of nicotine addiction therapy. And I will share the experience smoking cessation program in Taiwan Veteran General Hospital. The model will be Otawa smoking cessation model and very brief advisement. And last, I will talk about the World Non-Tobacco Day. In this year, the slogan will committed to quit and involve all specialists. So the first part I was talking about treatment and prevention of disease. An old Chinese saying, it tells us the best doctor is try to prevent from disease. And the average doctor means a middle-level doctor treat disease. And the mediocre doctor deal with severe and terminal sickness. So to be a good doctor, you need to prevent a patient from become very, very severe disease. And in today, because the aging population is increasing in all society, including cancer and chronic ear disease, will be more popular than before. What kind of chronic ear disease were related to smoking? You can see in Taiwan, the 10 leading cause of death in Taiwan in 2010 and 2020 will be cardiovascular disease, cardio accidents, and diabetes, COPD, chronic kidney disease, and chronic liver disease. All kinds of these chronic ear were related to smoking. Data from CDC in the United States, in their report, smoking-related deaths will be 408,000 persons per year. For example, lung cancer is the first leading cause of smoking-related deaths. And the second will be ischemic heart disease, and COPD will be the third. So smoking will be the confounding factor, and for all kind of chronic ear disease. So you can see the picture regarding lower respiratory infection, hypertensive heart disease, cerebral vascular disease, and diabetes and chronic kidney disease. All of these chronic ear disease where the risk factor will be smoking. So when a chest physician, they deal with COPD or asthma, if they neglect the smoking, the importance of smoking, they do the partially treatment of the patient. This reason is the same for a physician who care about diabetes, chronic kidney disease, and cardiovascular disease. For example, if we just care about hypertension, care about a lipid level, but we neglect the smoking status, it will be the partially treatment of the patient. And all of these chronic ear disease share the same risk factor: smoking, e-cigarette, badness in Taiwan, and alcohol consumption, and obese. So if we want to treat the patient comprehensively, we will not only treat the patient in their terminal disease and terminal ear. We should treat the patient in the early phase and prevent them from persistent harm from smoking or badness. So smoking is the major risk for all kinds of chronic ear disease. I will take lung cancer for example. In these 3 years, several publications regarding the effect of smoking of the lung cancer when the patient was diagnosed. This study contributed from UK. The aim of the study was to weigh the prevalence of smoking in diagnosed lung cancer in UK. And they were asked a very important question: whether smoking status as baseline and quit are independent factors associated with 1 year survival for this lung cancer patient. So the study design will be real-world cohort study following the patient from diagnosis up to 1 year or until death. So we can see 1,124 patients with newly diagnosed lung cancer were enrolled into this study. And you can see the 1 year survival curve. If the patient they were not never smoker, the survival rate will be higher than patient with active smoker or ex-smoker. So if the patient have the same status of lung cancer, but the smoking habit will change their life. And this is the subgroup analysis from this paper. For those who are active smoker, if they made decision to quit smoking, this decision will change their life for 1 year. I think the result is quite obviously, because in this analysis we can see patients who still smoking, the 1 year survival rate will be 53%, and the patient start to quit, the 1 year survival rate will 70. So start to quit should be a part of the cancer therapy. And another study contributed from United States. The study also asks the same question: the smoking status or smoking duration will affect the long-term survival for lung cancer or colorectal cancer patient. And this is also a nationwide prospective observational cohort study. This study enrolled 575 patients. And you can see they separated different smoking status into current smoker, never smoker, or quit in different duration. Again, you can see the long-term survival rate for newly diagnosed lung cancer patient. For never smoker, the survival rate is higher than active smoker. The hazard ratio was 0.71%. And if patient try to quit smoking, the survival rate was better than patient who still smoking. So again, this data also suggests for patients who diagnosed with lung cancer, smoking should be part of the treatment. And this is the current study published in Annals of Internal Medicine. It's a Russia study. The study also asks the same question to determine whether quit smoking after diagnosis of lung cancer is the independent factor for lung cancer progression or mortality. It's also a prospective design, and the lung cancer patient enrolled into this study were early lung cancer. They still can be cured by surgical treatment. And you can see the data. The smoking population in lung cancer patients remains high, especially in Russia study. In this cohort, there are over than 50% patients who were diagnosed with lung cancer and they were current smoker. And you can see for patients who continue smoking and quit smoking, the all-cause mortality rate will be decreased in patients who quit smoking. And the progression rate will also decrease when patients start to quit smoking. And you can see the lung cancer-related mortality rate will be decreased when patients try to quit smoking. So again, in a paper published in UK, United States, and Russia over past 3 years regarding lung cancer patients, we can see the same result. If patients try to quit smoking in their treatment, including their treatment of lung cancer, it will bring the best benefit for patient survival. And we do know smoking cessation is very important for all kinds of disease, including cancer and chronic illness. And so it's very important thing, but not an easy way to quit smoking. Why? For example, this is one of my patients. He was diagnosed with COPD, diabetes, lung fibrosis. He had very, very long period of smoking habit, and he has very poor lung function, and were diagnosed with fibrotic lung disease. And when on examination, the patient have obviously carving finger. You can see carving finger, and his CT scan show diffuse emphysema change and fibrotic change of both upper lung and the lower lung field. In this status, patient have a very obvious symptom. He feels dyspnea on exertion and a chronic productive cough with sputum. And I asked the patient, do you want to quit smoking? He said, I will try my best, but soon he gave up. And he took 2 years to quit smoking. So it's very difficult for patients to quit smoking. Why? In Taiwan, more than 3 million smokers. The average smoking amount were 17 cigarettes per day. Why this smoking amount is so important? Because all of smokers know that smoking will bring the risk of heart disease, lung cancer, and cardiovascular disease. And they also know the smoker will shorten in their lifetime. For example, a smoker will reduce more than 11 years of lifetime. But for them, it's still very, very hard to start to quit. Why? When we in clinical, we ask patients, do you want to try to smoking? They will respond to you, doctor, I will try my best to reduce smoking. But they don't know reduce smoking doesn't work. In fact, when you try to reduce smoking, it just effect in the few days, and the compensation effect of increasing smoking is very common phenomenon. And reduced smoking will not bring any effect of toxic inhalation. And in fact, reduced smoking will delay the time for start to quit. So reduced smoking is a rescue. It's not a standard of the smoking treatment, and it will delay the right time for start to quit. So from previous studies, reduced smoking can bring survival benefit. You can see the previous 3 publications in the United States and UK or Russia. Start to quit is the only way for patients to get benefit. Why is it so difficult for patients to start to quit? Because the smoking cessation is not a habit. It is nicotine addiction. So from the physiology, when we have nicotine receptor in our brain, when patients have nicotine uptake, the nicotine will bind with the nicotine receptor, and the nicotine receptor will release dopamine to let you feel very excited, and there is some addiction for patients with a long nicotine user. So what is the right time for patients to start to quit? I think smoking cessation should be thought generally of nicotine addiction therapy. So the right time for patient to start to quit will be when patient was admitted to acute exacerbation of heart failure or COPD or cardiovascular disease. So the doctor should seek the opportunity window to introduce smoking cessation program or treatment for those patients. Now we have very good nicotine replacement therapy or drug to help smoking addiction therapy to quit smoking, because the medication can bind in with nicotine receptor, and it still can release some dopamine. So it can help patient to quit smoking easier than reduce smoking. And what is the opportunity window? We will talk about the Otawa Model. In fact, in our hospital, we learn from Otawa Model and modify this model to build up our model. I think the core value of Otawa Model is a simple, systemic, step-by-step approach for addressing tobacco use in healthcare setting. So the smoking should start in the healthcare setting, including hospital and clinics and drugstore, especially in hospital. There are 5 components in Otawa Model. This model is published by Professor Andrew Pipe. He mentioned about 5 important steps regarding Otawa Model. The first step is identification. You should identify who are smoking in the hospital setting. And the second step will be documentation, especially document in the electronic medical records. And the third step was strategy advice and introduce pharmacotherapy. And we should have a long-term follow-up program. So if the patient they go to see the CV doctor or diabetes doctor, the doctor asks the smoking status. This is the first step of identification. And the doctor will record the smoking status into electronic medical record. And the patient, if the patient is active smoker, we can build up a referral system to give them strategy advice and give them pharmacotherapy. Then our case management will have a long-term follow-up to help them to quit smoking very easily in the hospital setting. What is the does this Otawa model work in work setting? I think from the previous publication, for the successful rate of smoking will increase after introduce Otawa model. So we can see the picture when the hospital setting introduced Otawa model, the smoking successful rate will increase 3-fold in patient introduced with Otawa model compared with they just quit smoking by themselves. They will not receive any help. So the Otawa smoking cessation model will be the systemic approach to providing smoking cessation education, medication, and the management. And some patients will ask me, doctor, if I if try to stop smoking is so hard, can I try e-cigarette to help me to quit smoking? And when we answer this question, I will let patients think about the harm and the lung injury issue in e-cigarette or vaping. Actually, vaping associated lung injury is well known and very popular seen from the previous journal. In previous journal, we can see many publications regarding vaping associated lung injury. You can see the CT scan. The patient have bilateral lung infiltration, and they have dyspnea, or they require mechanical ventilation support because vaping associated lung injury will progression into respiratory failure. This publication, this article has been published in New England Journal of Medicine and some of the theology paper. Why vaping associated lung injury is so serious? Because they have different chemical particle. When they are heated with a very high degree, in very high temperature, they smoke into our airway. It will bring airway injury directly, and the different chemical particle will bring different lung injury in CT scan finding. So some patients will suffer from acute eosinophilic pneumonitis. It is a kind of allergy reaction in the lung area. So, in fact, CDC had announced the outbreak of e-cigarette or vaping associated lung injury. Most of patients they were detected. Most of e-cigarette or vaping product contains THC. This material. This material or vitamin E acetate will be material that leads lung injury in bronchial alveolar lavage data. In fact, CDC named a new disease, E-valley. It means e-cigarette or vaping induced lung injury. CDC has identified vitamin E acetate from bronchial alveolar lavage data. So maybe this is a chemical of concern among people with E-valley. A recent publication published in JAMA, they include 160 cases of E-valley. In this population, 46% admit to ICU and about 30% require mechanical ventilation. And the finding from bronchial alveolar lavage, about 83% or 84% contains THC or vitamin E acetate. So e-cigarette will not be the total solution for smoking cessation. And e-cigarette also contain several different chemicals, for example, diacetyl, cannabis, methanol, vitamin E. It will bring lung injury for the user. And this particle will cause epithelial mesenchymal transformation. And if you expose this chemical for a very, very long time, maybe the epithelial cell will morphology change and become a cancer cell. So tobacco smoking and e-cigarette share the same pathway of lung damage. So using e-cigarette or vaping will not be a good solution for patients to stop smoking. And the final part, I will talk about reinforcement of smoking treatment. Our experience from Taiwan Veteran General Hospital. In fact, this program has been introduced since 5 years ago, and why we start to try to do this project, because many patients smoking, few patients refer to smoking cessation in hospital, and in that time, at that time, no systemic way to identify smoking in our hospital, and the subspecialists, for example, chest physician, CV physician did not join to the smoking cessation team, and no support from the policymaker in hospital. So the aim of this project is to build up and modify Otawa smoking cessation model in our hospital. We should identify the patient who are smoker and provide education, medication, and case manager for all smokers in the hospital. So the first version of a strategy map in our hospital will be we enroll the all case manager, including cancer case manager, diabetes case manager, COPD case manager, cardiovascular disease case manager, and chronic kidney disease case manager. Then we enroll this nurse into our team, and education, and they refer the patient to the full-time smoking cessation educator, and we give the treatment and medication, and we form a team to build up an efficient and rapid response team of a smoking cessation team in our hospital. And for all the chronic year, I think all the chronic year need smoking cessation. So the first step, we enroll chest physician, we enroll cardiovascular physician, we enroll neurologist, we enroll diabetes, and we enroll nephrologist into our team. So the smoking cessation model in our hospital will be modify Otawa model and a very brief advice and become a team. So we will do we are not doing nicotine addiction. We are not doing the smoking cessation. We are doing nicotine addiction therapy for the patient. What is the very brief advice? Very brief advice means we just use simple word to give the advice for all patients within 30 seconds and give the opportunity to start a smoking cessation plan. We just use three strategies: ask, advise, and act, and give patient treatment suggestion. So every patient in any consultation will be started in our hospital. We are told the patient stop smoking is the single most important thing you can do for your health. And we provide help, and help is available anytime, anywhere in our hospital. Would you like some help to quit? So this program can be introduced in any visiting in admission department or in the OPD department. It's available for all patients. They seek for help in the hospital. So in 2020 we have a new we have a new department, is Smoking Cessation Treatment and Management Center, SCTMC. And the superintendent in our hospital joined the program and give our support. We have new education room, and we have program to enroll patients to join the education class. Now we have the second version of smoking cessation strategy. We enroll not only smoking cessation case manager, we also enroll all specialists. They want to do some help in smoking cessation for patients. And we have two full-time smoking cessation project manager and coordinator. We use IT platform, we use social media, and we form a research team in our hospital. So the version 2 of a smoking cessation strategy back in our hospital is more stronger than the first version. In this model, Otawa Model, smoking cessation model, and the VBA in all chronic year, we increase the smoking cessation rate more than 50%. We have six spotlight. The first spotlight is we training specialists to join our team. Previous, this specialist is only focused on family physician, but now we join all the specialists, including pulmonologists, neurologists, or cardiologists into our team. The second, we training case manager to provide smoking cessation service in every chronic year patient. For example, diabetes, heart failure, or COPD. And we use IT support to build up a remote dashboard of smoker. We can easily find where is the smoker and where is the patient we can give some help for let them join the smoking cessation team. And we also have a new department, Smoking Cessation and the Management Center. It provides the all hospital smoking cessation strategy and the resources. And we also uniform the recording platform for all in the hospital. We can classify the Bethanate, the e-cigarette, or smoking amount for all patients. And last, we cooperate with specialists to form the modified smoking cessation model in our hospital. For example, for heart failure, for COPD, the physician can do smoking cessation program in the OPD. What about the smoking cessation rate in our hospital? I think the smoking cessation is quite good in our hospital. Now we have the smoking cessation rate in the 3 months will be 60%, and the 6 months will be 55% currently. So we get several awards in our hospital, and we also get the Innovative Award in smoking cessation. So let's go to the last part. In this year, World No Tobacco Day, the slogan will be "Committed to Quit," and we add some slogan. We suggest in "Committed to Quit" should be involve all specialists, including physician care about diabetes or COPD or heart failure. So smoking will bring the most benefit for all patients. And not only family physicians join the team, we think all specialists, including physician care about COPD, heart failure, diabetes, chronic kidney disease, should join with a smoking cessation team, especially in COVID-19 pandemic area. For COVID-19, severe COVID-19 patients, if they still smoking, they will have more disease severity and higher mortality. And now we try to define the best way of smoking cessation in Taiwan. So we have 8 hospitals to join together to modify, to discussion what is the best model and best strategy to give the comprehensive smoking cessation program in the hospital base. And we have 8 hospitals and many physicians, nurses, and to join our team to discussion. And finally, we will give a manuscript to submission to share the experience in Taiwan. So I will have some take-home message. First, smoking cessation is the best way for all chronic illness, including COPD, diabetes, CAD, heart failure, and CKD. Smoking is correlated with survival in lung cancer. You can see for new diagnosed lung cancer, if patients try to start to quit, the 1-year survival rate will increase. So non-smoker, the survival rate for lung cancer patients, non-smoker is better than ex-smoker and better than current smoker. Smoking cessation will bring great benefit of lung cancer in regarding all-cause mortality, progression-free or lung cancer specific mortality. Smoking is nicotine addiction therapy, and in the smoking cessation model in our hospital will be Otawa cessation smoking model with a very brief advice. E-cigarette and smoker will increase the ACE2 receptor and increase the mortality of SARS-CoV-2. So e-cigarette were not the total solution for start smoking. So let's go back to the old saying: the best doctor prevent from illness. The average doctor treat disease, and the mediocre doctor deal with severe terminal sickness. I think every of you are the best doctor. So we try to prevent patients from illness. and smoking should be involve all specialists. Thank you for your attention.
Thank you so much for Dr. Phuc for your very concise talk about 50 minutes of your experience. So I come to my second speakers. I would like to introduce you that we have a very well-known tobacco control doctor in Thailand. So my second speaker is Associate Professor Suthat Lungleung. Now, he is at the Division of Pulmonary and Critical Care Medicine Department of Medicine, Faculty of Medicine, Srinaklin Virod University. And he also my scientific chairman of 30th APACT. And he also a committee in the National Alliance of Tobacco Free Thailand. So I would like to have you welcome Dr. Suthat Lungleung. Dr. Suthat, please.
สวัสดีครับ Good afternoon, everyone. Now I'm going to talk about the reinforcement strategy for successful smoking cessation in Thailand. First of all, this is going to be the outline of my talk. I will start with the beginning of the cessation system in Thailand and what we are exactly doing, and what will be evolving in the near future in Thailand about the smoking cessation system in this country. I believe that, I'm not sure how other countries would be, but in Thailand, cessation is always the weakest link for tobacco control in this country, especially if you consider about the Empower scheme, the O, which means offer help to smoker to quit, which is the smoking cessation, is always caused the problems over the past several years. I remember when I started my smoking cessation clinic about 10 years ago, we started from scratch. We have nothing, and not even the patients. We have 0 patients in our clinics. There were no patients at all. But we still had to do because of this patient. This is one of my very first patients in the hospital. He was admitted because he had broken legs, and he smoked while he was admitted in the hospital. So we had to initiate the service for this guy. And since then, we maintain the service to help our either inpatients or outpatients to easier and better than before. And that small part that happened about 10 years ago when I set up my clinics really represent what exactly happened in terms of smoking cessation in Thailand. There was a Thailand capacity assessment in smoking cessation in 2008 by the World Health Organization expert came to this country, and these are what we got in terms of the comments and suggestions from the WHO expert. First of all, they said the Ministry of Public Health of Thailand gave tobacco dependence management a low priority. Secondly, tobacco cessation is not funded. It's completely 0. Utilization of service was very low, like I mentioned earlier. And moreover, national systematic multi-level treatment system integrated into the primary care system does not exist. So means that the smoking cessation in Thailand was among nowhere, nothing really helped us. And that can really lead to what happened in Thailand several years ago. Thailand smoking rate was disappointingly plateaued. you could see that in 1991, the smoking rate of Thai people dropped from 32% to 28.8% in 5 years. But the dropping rate was slowed down progressively. And now you can see since 2009, the smoking rate among Thai people decreasing very, very slowly, or not even decrease at all in 2011. So this is really caused us a concern about tobacco control in Thailand, that smoking cessation has to be improved markedly in this country. So what we did was, there were two things that we did at that time. Firstly, we strengthened the pre-existing smoking cessation services, which is very minimal number. There were only not more than 50 clinics nationwide that still open for the cessation service at that time. And since 2009, the smoking rate among Thai people decreasing very, very slowly, or not even decrease at all in 2011. So this is really caused us a concern about tobacco control in Thailand, that smoking cessation has to be improved markedly in this country. So what we did was, there were two things that we did at that time. Firstly, we strengthened the pre-existing smoking cessation services, which is very minimal number. There were only not more than 50 clinics nationwide that still open for the cessation service at that time. And mostly, there were only 1 or 2 new patients per month. Secondly, what we want to do is to establish and support newly developed services, which there were several things we have to do to establish and build up a new network so that we can strengthen the cessation service in this country. These slides show what exactly we have to do to establish the service networks in this country. We had to develop the toolkits and educational materials, guidelines. We have to do the training and networking. We have to think about the incentive, medications, devices that we require in the clinics. And of course, what we cannot really forget is the government policy. The policy has to support the personnel and the hospital to maintain or promote the service and the personnel that work for that services, so that they can have their career path in terms of the cessation services in this country. So this is what we did. We established what we call Farsight Clinic Network. And I will tell you why it has to be named Farsight. We developed several books, toolkits, guidelines. There are several versions of guidelines, and the most recently updated was done in 2021. And we have training more than 4,000 healthcare professionals, including medical students and the nursing students. And this is the picture show you that the National Clinical Practice Guidelines Smoking Cessation, the most recently updated, was done in December 2020 and would be released very soon from now. And there were at that time several leaders and national experts from 31 organizations, including the Royal College of Physicians of Thailand and the Healthcare Quality Assurance from the main office too. And this is the logo of Farsight Clinic. We have the idea about making it the chain business. We have the name of Farsight Clinic everywhere in the country, in every hospital that people can go in and receive their cessation services. That's what we believe. And Farsight, the name means blue sky, means that we don't want to see any smoke or vapor from e-cigarette that will interfere and make the sky dirty. What we did was that to enroll to become one of the Farsight Clinic network, the personnel has to enroll themselves into the system, receive the training and strengthening. We have the protocol and software they have to use in their clinics. They have to be trained to develop skills in terms of the cessation. We had a small amount of budget from Thai Health Organization, and we had the medication that we prepare from Thai Health Organization as well. And also, once they start doing their services, we start to collect the data, and we send the auditors, trainer, instructors to teach them to collect the data, feedback them how to improve the quality of their services. We reassess, try to standardize the services from any clinics. Means that when the patients go into any clinics, they will receive exactly the same standard of care. And once we receive, we learn which clinic can give a good performance. And we'll do the knowledge management and sharing to others so that they can learn from the best and they can improve their quality of care later on. This is what exactly Farsight Clinic Network did. And we start from only 5 clinics in Bangkok. The network expand to 550 clinics in 5 years. This is what exactly happened based on our Farsight Clinic service. So, in short, if we talk about what we exactly currently have in terms of cessation service, of course, we have Farsight Clinic network that will provide the service, the face-to-face service, like I mentioned earlier. We have the Quick Line, which has been developed about the same time too. And we have also the drugstore network that would like to be able to give the counseling to those smokers who want to quit. But what we have at the moment is that Farsight Clinic, Quick Line, and the drugstore, they just work on their own. There's nothing to communicate among these stakeholders. So we want to connect them to each other, but we have to wait for the policy, and we have to wait for the technology that could help us to connect each other. Once the technology is better, we start to switch our educational toolkits and material from the paper one to the electronic one. This is what exactly you could see in our website, thailandsmokingcessation.com. There are books, there are materials that you can download as PDF file or PowerPoint file for free. This is also the website that show and teach the personal about very brief advice. And there will be a platform that people could learn how to provide the VBA to their patients to help them quit better. We also initiate, at first we have the application to collect the data. After people gave the cessation service to patients, they have to record it on the mobile application. But now we say we already had it run for several years. It is time to hand it to the government. So now the Ministry of Public Health has the authority to run the application, the database of smoking cessation service. And we use this kind of database to connect Farsight clinic and other stakeholders, including Quitline and drugstore, so that they can use the same database service. Once they provide any services to certain patients, they just key in the data of that patient into the cloud system that collect all the data. So once the patient was referred from Farsight clinic to Quitline, Quitline also can access the electronic chart from the cloud system to see what exactly the clinics provide as a treatment for this patient last visit. So there will be continuity of the care, and it means that in the near future, once the system is completed, developed, the patient could receive the smoking cessation services anywhere and anytime. And in the future, we are going to develop the teleconsult for the smoking cessation service as well. But one problem in this country is that the smoking cessation medication still not in the national essential drug list. So there are two jobs at least that we have to do. We have to find the best medication we can afford and try to give that answer to the government. And we try to establish good evidence for the government consideration so that they would say, no, you cannot have this medication in the ED list. So we did a big trial. In fact, it's a real life. It's not the randomized controlled trial, but it's the real life study, the clinical trial. We assume that one province in Thailand is the real Thailand country. We set up everything, like patient could go into any hospital and receive the medication, which the medication we chose at that time to be in the system is varenicline. So patient could go to any hospital and receive the cessation service, and there were the database system that were online throughout the entire province at that time. And the province that we chose was Nakhon Ratchasima or Korat in short. So we got 2,000 patients. One group received varenicline and the other one received only Castellan. So what interesting is that there were 84.5% that smoke less time to first cigarette is less than 30 minutes. Means that they are the hardcore smoker. And so if you look this column, it means that the patient who receives varenicline tends to be more hardcore smoker than those who receive no medication at all in this trial. What we found is that despite of the fact that this group who received varenicline is a lot more hardcore smoker than the other group, but the cessation rate or success rate is still higher in this group who receive varenicline. The cessation rate up to 39.3% at 6 months. Besides varenicline, also other kind of medicine from other sources as well. We want to push nicotine replacement therapy to be a household medicine, means that people could access to NRT at the retail store anywhere. That's what we would like to see. We would like our cessation service is not just limited to the clinics or to the quit line, but they can go to 7-Eleven, they can go to convenience store next door to their residence and go buy whatever they want to use to quit smoking. For example, in this country, we plan to Cessation. And there is another medicine is being made at the moment is Cessation for the new drug registration process. So it will take several years from now before the drug success. We also did the studies for the cost utility analysis based on our performance of the Farsight clinic network. For example, this study was done by Dr. Nathon Chayakumaput team, and so the results show that Farsight clinic is cost effective for COPD patients. For example, this is what we're trying to make evidence to help the government to consider to support the smoking cessation services as one of the health service nationally. And so up to this point means that exactly what we currently have, we have several things, both human resources, services, but the weakest link in terms of the cessation is the government policy, which is, I said, the gap here. We don't have the smoking cessation medication in our national drug list, and the government still doesn't have the clear policy support to the smoking cessation services at all up to this point. But for the rest of the we have everything ready for that. We have the training system, both the provider courses and the instructor courses. We have the academic work and researchers. We have surveyed our healthcare professional for smoking status. From time to time, we have all the educational tools online ready. We have the tests, for example, the soluble nicotine tests are being made. And in terms of the service, National Quit Line is going to be sponsored by National Health Security Office in 1 or 2 years from now, which is quite a good news for us because it will help to secure the National Quit Line service from now on. We have the Farsight clinic, which is going to expand into the NCD clinics nationwide. We have the database system, which is being made nationally at the moment, and we're trying to push the smoking cessation medication into the national essential drug list at the moment. That's part of what we have done, a lot of things. We still see that the smoking rate of Thai people still in the plateau phase, but some experts say it's quite good enough because we have a new threat, which you guys probably can guess it is the e-cig, which in several countries the smoking rate is jumping up after the system was attacked by the e-cigarette. But despite having the e-cigarette in our country and being most popular among youth, but we still can maintain our smoking rate among adults in this country going down, even though slowly. This is the evolving system that we are heading to. We want to promote the quit line to be able to expand their service to serve all the people nationwide. We want to bring the IT system to help us to connect the clinics, drugstore, and the technology-based service. For example, the teleconsult. We have the database system in the cloud, and whenever the quit line would like to provide the medicine to the patients, then they can generate the QR code, send it to the patients, and ask them to go to either clinics or the drugstore to receive the medication. And then after that, they perhaps can be followed up through the teleconsult system in the future. We want to make everywhere available for smokers to quit in our future. Means that the smokers who want to quit can go to convenience store next door, go to the community clinics, or even the drugstores to receive their counseling plus or minus medication. So, in summary, I would like to say that the establishing and supporting newly developed service in Thailand are in process. Clinics and quit line are moving forward. The persistent gaps are always from the government policy. And next, we are in the process of pushing certain smoking cessation medication, especially the varenicline, into our ED list. And lastly, national database system in smoking cessation and IT-based services are being made. And this is pretty much all of my lecture. Thank you very much for listening. Have a good one.
So thank you so much for Dr. Sutat. You are a very valuable share of your experience about the successful cessation program. So it comes to the time of the question and answer. On my hand, I have one question for Dr. Sutat. Can you share how you run about the Farsight clinic in Thailand, and what is the factor for the successful of the cessation program in the Farsight clinic? Dr. Sutat, please.
Thank you very much, Professor Ronachai, for a good question. What I have to say is that the way we run Farsight clinic, we have to make it clear to those who are who come into the program. We have to make sure that those who have been recruited, they have to receive what they are needed, what are really the gaps. For example, they really need the protocols to run their clinics. They really need certain training to provide a good services, and they need the incentives, and also the other thing is that they need medication. They need devices, for example, the exhale carbon monoxide meters. Those are really the most important things that will fill in the gap that the providers of the services will need. And if they feel that they got what they really need, then I think that the system and the network will keep growing like we are doing right now. So what I have to say about the successful factor is that one thing is that the participant of our Farsight clinic network, they have to feel that this is their own network. It's not my network. It's not the network of Thai Health Promotion Foundation is not certain person's network, but it is their own network. They come, receive the training, receive what they need to provide services, then they go back, they treat their patients, help them quit smoking, and they keep collecting data, come in and share their experiences, their good practices to their friends in the networks who work somewhere else. So this is make them proud of being one of the member of Farsight Clinic, and this is another successful factors for the Farsight Clinic. This is what I would need to tell at the moment. Thank you very much.
So thank you so much for Dr. Sutat. You are very concise answer. So this Untitled program is come to the time that we have from the 30th APACT meeting. So I myself would like to thank for my two valuable speakers have been share a lot of their experiences and how to run a successful cessation program. So I think all of today's knowledge will share to all of you and will be can be extended how to have total control in each setting of your country. So thank you so much for your joining this luncheon program. Thank you for your attention. Goodbye.